Hello and welcome friends. Today I'll discuss your image book or the workbook of neuro and endocrine which you've already got with yourself. Now let's start with the very first question that has been in the image book. You have just admitted a young man with a past history of seizure disorder who has just witnessed to have a focal seizure at home. His family description is suggestive of focal seizure involving the left half of the body. So we have got some key points in this question that the patient had suffered with a focal seizure at home involving the left half of the body, and there has been a past history of seizure disorder also with the patient. Now he's brought 2 hours after the symptom onset. Currently he is awake, conscious, oriented, and the power in the left upper limb where he had the seizure is nil, that is 0/5. The rest of the neurological examination in the patient is perfectly normal. Another key point here, the CT brain of the patient is normal. It doesn't show any kind of space occupying lesion maybe at present, and could be any kind of a traumatic brain injury picture on a non-contrast CT of the brain. Now the question moves from here that what is the best course of action at this time? If you have attended my classes in the online segment this year, that you would realize that we have already done this question. So one thing is very clear, that this patient had a focal seizure at home without history of loss of consciousness. So it was a patient who had a focal seizure with intact awareness. Now what we have is a neurological deficit, that is the power in the limb is 0/5. Now if you remember, a patient with a focal seizure at home develops a neurological deficit in the same limb where the seizure happened is known as the Torts palsy. Now the good thing about Torts palsy is that it's self-recoverable. It doesn't require much of attention at the present, just a diagnosis will help, and it will recover on its own. So what are we going to do next in this case? Reassess in few hours, right? Cerebral angiogram is something that is done to find an aneurysm in the brain, but that would only help when the patient has got a disease like subarachnoid hemorrhage, SAH. Now look at the question again. This particular history doesn't fit into a history of subarachnoid hemorrhage 1, and most important, the CT scan doesn't reveal a subarachnoid hemorrhage. So doing a cerebral angiogram is just waste of time and money both. Lumbar puncture is something totally out of syllabus because he doesn't fit into a history of a CNS infection either. Okay, because if you remember meningitis, if I'm suspecting, I should have fever, I should have headache, I should have altered sensorium. We can have seizure also in cases of encephalitis, right? Now psychiatric evaluation is something not very well here because there is a past history of seizure disorder in the patient. So going and labeling him as a case of pseudo seizure won't really help me. Okay, so reassess in few hours is the best answer. Now going on to this image, what does this image show to me? As you can see in the very first one, that the person is having a seizure involving the left half of the face, right? There is some facial deviation with some eye closure, and you can see the dotted lines that basically depicts the movement of the head region. Now after that movement, the patient had a seizure activity involving the thumb and the index finger. So again the dotted lines show the movement part of it, and now the seizure went on to involve the forearm of the patient. So what do you see in a progressive fashion? In the same patient, the seizure started in the face, went on to the hand, and then moved to the entire upper limb, right? So the onset of the seizure was at a particular point, that is the face, then started involving the entire left upper limb of the patient. So what do you see this as? Focal seizure, right, with secondary generalization. Now be careful in these words. Why am I, when I'm telling you secondary generalization, that means it becomes generalized later on. Although in the picture I could not show it well, that even the lower limb of the patient got affected later on. So it started at a point and then became generalized. You should have an understanding why it would have had happened, although this image is not well connected to the question at the moment, because in a patient with focal seizure with secondary generalization, there was a discrete lesion in the brain surrounded by a lot of cerebral edema. So you understand this, wherever the discrete lesion is sitting upon, right, At that particular point, the motor cortex, that particular limb is going to have a seizure activity. But as you can see, because of the surrounding cerebral edema, the seizure is going to spread everywhere. So that is a focal seizure with secondary generalization, right? Now the common confusion comes into your mind, so why don't you call it as a Jacksonian march? If you remember, Jacksonian march was again a focal seizure, but it was restricted to only one particular limb. Let me show a video to explain what I'm trying to tell you. Now this is a patient with a Jacksonian march. Seizure started in the fingers, went on to the forearm, arm, and then to the shoulder, right? So Jacksonian march is a restricted seizure activity involving only one limb. While focus seizure with secondary generalization will start in the right upper limb, went to the face, and then the right lower limb. Okay? Stop. So this is something, a focus seizure with secondary generalization. That means it involves one side of the body or may involve the whole body later on. Okay? So we got two things. What have we done in this particular question and what does this image really depict about, right? Now second image is very clear. This is a patient with a seizure activity which you know as the myoclonic seizure. A sudden jerk had happened in this patient that led on to the drop of the toothbrush and the toothpaste in the patient hand. That is known as the term myoclonic seizure. Sudden jerky movement, right? Now neuroimaging is normal in, that's a question that stands here. Is it normal in a patient of focal seizure? No, no, no. If you remember, focal seizure started because of a discrete lesion and that discrete lesion will always be picked up on a neuroimaging. Temporal lobe epilepsy, another favorite topic of your examiner, is diagnosed on neuroimaging. If you remember, we had the large temporal horn, small temporal lobe, and hippocampal sclerosis in the patient. While juvenile myoclonic epilepsy is somewhat odd when out. If you remember, JME was a seizure type which was most of the time of an unknown cause. It was seen as idiopathic. So if you remember the word myoclonic seizure, any time in any patient you saw, you please think of 2-3 things together. Either patient is having a hypoxic injury in the brain like infarct or some kind of a ischemic insult to the brain, or maybe the patient is having some degenerative problem in the brain, atrophy. Just a quick example on this, you studied with me the prion disorder, prion disease, the Creutzfeldt-Jakob disease. One of the characteristic, or rather the most common symptom in a CJD patient is a myoclonic jerks. If you remember, CJD was a neurodegenerative disorder by some kind of a infectious protein that were known as the prion proteins, right? So atrophy stands here as a cause for a myoclonic seizure. Now apart from this, don't forget that we also see another cause, that's metabolic of myoclonic seizure, right? Now metabolic is a big thing, it can happen due to any electrolyte imbalance, even any kind of a derangement in normal metabolites in the brain. So again, myoclonic seizure occurs due to hypoxia, atrophy, and metabolic. Just a quick revision on a simple fact that we have discussed in the classroom also. If you remember, we had a tremor, flapping tremor, right? Flapping tremor. I've got an image on that also later on lined up. Now, flapping tremor was a flap which occurred when the patient held a hand in a position in which he was trying to extend the wrist joint, okay, and it suddenly went down and went back. If you remember, the flapping tremor happened in a lot of encephalopathies, right? Those encephalopathy, the common ones like the hepatic encephalopathy, the uremic encephalopathy, and the respiratory encephalopathy, also known as CO2 narcosis. Now, in the class, I've also explained this. This flapping tremor is also known by another term. Negative, yes. Myoclonus. If you remember the myoclonic jerk, a sudden jerk which occurred. Now the word negative came here because the tone of the muscle went down at this point. Normally in any myoclonic jerk, the tone increased, while in negative myoclonic jerk, the tone decreased, right? Now how am I connecting all this thing? There is a myoclonic jerk which is negative myoclonic jerk. which occurred in patients with metabolic derangement, right? And that metabolic derangement was encephalopathy. Now remember, this metabolic derangement was due to failure of the liver, that is the hepatic encephalopathy, failure of the kidney to work, uremic encephalopathy, failure of the respiratory system to work, respiratory encephalopathy, or the CO2 narcosis, right? So maybe a kind of a connection that you can draw here, right? Now we got myoclonic seizure, myoclonic jerks. How do they really look? We have seen this video in the classroom also. The sudden jerks which occur, I've tried to show it in one half, that is the right upper limb, but it can occur in the whole body at one time. Okay, so they can be generalized, they can be focal, we already know that. Now the next question is another question that we have done in the class 1, and this image is describing a person whose age is 14-year-old male and presents with a sudden staring look. The patient looks at me and stares at me suddenly, followed by a confusion, right? Okay, so what is the likely diagnosis? We've done this question in the classroom, if you remember. One thing which goes out at the first is absent seizure. Yes, you all know this because absent seizure doesn't have any post-ictal confusion, right? Correct. The myoclonic seizure presents with a typical jerky movement that now we have seen. The word atonic is describing the word itself. The word is describing the presentation. There is loss of tone. So these patients might come to me with a history of typical fall sometimes, right? Now what are we left with? It's a focus seizure with an impaired awareness. Yes. When the person from a normal look goes into a stare look like this, he is losing contact with the environment, he is not responding to me, he is not aware of what's happening around him. So he is a patient of focus seizure with impaired awareness, right? Now just a quick recap of the things that we have discussed in the class, that what are the key differences that we find between a patient of complex partial seizure, right? Now the word complex partial is still remaining in the textbooks, especially the pharmacology. I've seen there, still it's there. Now the word complex partial seizure is another name for focus seizure with impaired awareness, right? Now how do we differ the two? Neurological status. First of all, remember, in an absent seizure, the neurological status is normal. That means there is no kind of a focal neurological deficit in the background which is seen in the patient, right? And in complex partial or focus seizure with impaired awareness, we see what? We see a positive history or maybe an examination in the background. Now this positive history is regarding the family history. I'm not correct here. It's not regarding the family history. There is a past history of any kind of a focal neurological deficit which the patient has suffered with, and of course on examination I might find it also. Okay, now remember this, that the partial or the focal seizure happened due to a kind of a discrete lesion, and that particular discrete lesion will always have a focal neurological deficit in the patient. Now a point here, the petit mal absent seizure started in the childhood or adolescence. It also starts in adolescence in some of the cases. And complex partial seizure can happen at any age. There is no age preference here. Okay, this can happen at any age. Now aura, if you remember, is absent in a patient of absent seizure, while aura was something which is very common in a patient of focal seizure. The onset in patients of absent seizure of loss of contact with the environment is abrupt, while in patients of complex partial seizure is seen to be gradual. It starts minutes or time. Now the duration of loss of consciousness, if you remember, in absent seizure was in seconds, less than 30 seconds, while in complex partial or a focal seizure it can happen up to minutes also. Automatism, subtle motor signs. Yes, very important thing. If you remember, subtle motor signs were present in a patient of absent seizure as well as in a patient of focal seizure. Provocation by hyperventilation for minimum a minute time is very common in patients of absent seizure. It's very uncommon in patients of focal seizure. Termination of the event is abrupt in focal seizure, absent seizure, while it's gradual in a patient of complex partial seizure or a focal seizure. Frequency, again important thing. Remember this, frequency, possible multiple seizures happen in absence seizure patient. Why? Because if you remember, the onset of this problem is often in a childhood age. And you know the kids, they never stop. They've got tires in their legs and they keep on running all across. So running everywhere will induce what? Hyperventilation. And hyperventilation will provoke this kind of a disorder. Absence seizure, simple. While on the other spectrum, the focus seizure with impaired awareness, the frequency is often occasional that we find. In patients of absence seizure, there is no post-ictal confusion. Okay, remember this, there is no post-ictal confusion in patients of absence seizure. While in focus seizure with impaired awareness, there is a lot of confusion, fatigue, which is post-ictal seen in them. EEG generalized here spike and wave is seen in patients of absence seizure, right? While focal changes will be seen in patients of focal seizure. Now another very important point, neuroimaging is normal in patients of absence seizure, while in patients of your focal seizure you'll find some focal lesion in the brain, like a discrete lesion. Now we've got two things lined up now. A patient who has got a normal neuroimaging, I've discussed this in the classroom also, could be a case of absence seizure, one, or it could be a case of juvenile myoclonic epilepsy, right? Now I'll just show you the videos that you might have seen in the classroom also. A patient of focus seizure is smelling here and there, he is having some hallucination or olfactory, and then suddenly goes into a stare or a trance phase, has got some eye blinking, that is your automatism, followed by a lot of post-ictal confusion. Simple. Now absence seizure wala patient, yes, okay, will hyperventilate, go into a trance phase with some subtle motor signs, and most important, post-ictal, nothing happened wrong with him, all is well. Okay, so that's a case of absence seizure and a complex partial seizure. Now the next image is a patient who has suffered with a seizure episode, generalized tonic-clonic seizure. Like, how does it happen? Now first of all, look at this image. There is flexion of the upper limb and some extension of the lower limb that is seen, that is the tonic phase. Then there is sudden jerky movement that has occurred in the patient, that is a clonic phase. And of course, in the post-ictal phase, we find the patient's limb are totally not moving, they are flaccid, right? Now the question stands here is that arrange the symptom in a patient of GTCS in a sequence of occurrence from the beginning till the end in the episode of GTCS. Now if you connected everything together, first of all, in a patient of a GTCS, there is a pre-monitory symptom which happens. Got it? Like my patient will have some kind of an abdominal pain, nausea or palpitation, which you can write as a word prodrome also, but not always as a word aura, because aura is something which is more typical in a patient of focal seizure, not in a patient of generalized seizure. Okay. Now there can be a prodrome or a premonitory stage, which can be a vague abdominal pain or any kind of other autonomic symptom even. Followed by this, there is a tonic phase, right? Now the word tonic means that there is increase of tone in the body, like the upper limb goes flexed and the lower limb might stand extended. We have discussed this in the class. It's a sort of a rigidity which occurs in them, that is the decorticate rigidity. At this moment there is contraction of the intercostal muscles on the lungs and contraction of the laryngeal muscles also. Now the air will move out from the lungs under a force through a closed orifice. That will release the air under pressure, causing what? The till cry. At this moment the patient might develop cyanosis also, because the air cannot move into the lung because of the closed glottis this time, right? Followed by a phase of jerky movement, that is the clonic phase that we see in the patient. And of course the post-ictal phase, which will be showing more of flaccidity, not tonicity or clonicity. And at this point we find most of the time urinary incontinence in the patient. Now you might look at the image and point out, sir, urinary incontinence was seen in this case in the tonic, clonic and maybe post-ictal phase. I got this image from the web actually. It depicted the GTC is better than anything else actually. Maybe this case is having a second or a third episode of Caesar. He might have urinary incontinence in the previous episode. So you please just neglect that vetting part. Okay. Now the question stands here is that from beginning till the end, in an episode of GTCS, please arrange the symptom in a sequence order. So the first thing which happened is a premonitory symptom, number 4, right? Followed by a tonic phase which showed an ictal cry, number 2, followed by a clonic phase, that is a jerky movement, and then followed by urinary incontinence. So the sequence is 4, 2, 1, 3. Correct? Right. Now, these are the questions that we get in the AIMS pattern very often. I believe they are simple ones because if you know the first and the last wala, you can easily answer the question, right? Now let's see the video of this patient of GTC that we have seen in the class also. Patient had aura phase, abdominal pain, followed by a tonic phase with an ictal cry, followed by a jerky phase, that is a clonic, and then, yes, patient had a lot of flaccidity. Now the next question we have done in the class, a person waiting for a train on a railway platform starts having a seizure. He has a band showing him to be an epileptic on medication and his medication are in his pocket. Okay, so he is carrying a proof that he is an epileptic because he is wearing a band which shows that he is an epileptic, right? So he is carrying his Aadhaar card for the epilepsy. And the good thing is that he is having medication in his pockets also. Now what is the next step that you can do for the patient? Remember, first of all, remember this, in an epileptic patient, as I've tried to show in this image, we should try to stabilize the patient. Like in this image, there is a bag or maybe a cloth which has been placed below the patient's head and the neck region. Now any patient who is having an episode of GTCS, maybe outside the hospital, you should try to stabilize the patient and place the patient in a very safe kind of a position. Now the word safety doesn't stand for the patient getting injured maybe in other parts, but on the head and the neck region also. So if I place something like a cloth or maybe a bag below the patient's head and neck, maybe I'm stabilizing the head region, and in an episode of GTCS, especially in the clonic phase, it might hit the head, might hit the floor, and there can be some kind of a head injury in the patient. Just to avoid that, we do this. Second thing is in the image shown that we try to place the patient in the left lateral position. Possibly that's the safer one. The chances of aspiration is very less in the left lateral position. Now there's a way of putting the patient in the left lateral position is to hold him on the shoulder, hold him on the hip or maybe the knee joint at this moment, just to turn him. Later when the patient goes into that position, place him like this, okay, and still hold him on the shoulder in the back region. Don't hold him on the feet and the hand because the chances of dislocation and fractures if I try to tightly hold him in maybe a tonic or a clonic phase. The reason behind all this maneuver is one, that we try to prevent injury in the patient by placing him in a safe position. Second, we try to prevent aspiration by putting the patient in a left lateral position, and you never know. This may be the first episode, another second, the second, third, fourth and fifth episode goes on. So what should I do now? Now looking at the question, take the person away from the train, give him medication and water and then transfer him to the hospital. Never do this. Again, he might have a second, third episode. You never know after 2-3 minutes. And if you have fed him with water, yes, he will drown in that water to do what? Aspiration. Never do this. Take the person away from the train, make him lie down by holding his legs up. No. That sounds to me like some kind of a maneuver which I do. If the patient has suffered with an episode of what? A syncope. Okay? Only then. Right? Now take the person, now first of all, it's not a case of syncope at all because he is having a band showing him to be an epileptic. His medication are in his pocket, so I don't think so it's a syncopal attack. And take the person away from the train, stuff a handkerchief in his mouth, hold his hand and feet till the seizure subside. No, 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 no. Putting a handkerchief in his mouth won't really help me. No, it might damage the patient, because if the handkerchief goes into his oral cavity, he might just gag with the handkerchief. Okay, so that doesn't make sense at all. Take the person away from the train, make him sure he doesn't fall, meanwhile call for medical help, and then transfer him to the hospital. Yes, that's the right decision on a railway platform that you can take, right? Because call for medical help, transfer him to the hospital, because it might reoccur. Seizure is something which is very recurrent kind of a thing, and you never know this patient has missed his medications. So in this setting, it's best to transfer him to the hospital as early as possible. Right. Now, this is something which you have understood in classroom also, that an injectable phenytoin is never diluted in a dextrose containing solution. Why? Because phenytoin precipitates in a dextrose containing solution. It becomes like this, milky white. Right? So that's the reason behind that. Now, there is an assertion injectable phenytoin never diluted in a dextrose containing solution, and there is a reason behind this. Phenytoin causes hyperglycemia. Wait a minute. Phenytoin causes 6H. Yes, quick revision. It causes hypersensitivity, it causes hyperglycemia, it causes hirsutism, it causes hyperplasia of the gums, it causes Hydratoin syndrome, and it can also cause hepatitis. Yes, but phenytoin causing hyperglycemia, is it the right reason for not mixing the injectable phenytoin in a dextrose containing solution? No, I agree. Reason independently is a correct statement. Yes, but it's not the correct explanation for the assertion. So both A and R are true individually. But R is not the correct explanation for A. No, no, no. That's not the correct explanation for A. The correct explanation for this assertion is that the phenytoin on mixing in a dextrose containing solution becomes milky white like this. It precipitates in a dextrose containing solution. Right? Okay. Now in this image, as you can see, there is a person who is standing. Okay. And on the other spectrum, there is a person who is either standing or lying down, right? So this is nothing but a quick comparison between an episode of a syncopal attack or a syncope versus a patient who is throwing a seizure. Now, as you can see in this image, the very first thing is that in a patient of a syncopal attack or a syncope, we find that they are most of the time in a posture which is erect at the onset. At the onset of a syncopal attack, we find them, they are in a position which is often erect. If you remember, if you stand, the venous return towards the heart will obviously get down or will be lower than what you have in a lying down posture, maybe even a sitting posture. While in a seizure episode, the position at the onset of the patient is often variable. That means it can be sitting, it can be lying down, it can be anything. It's variable. Now, this downward thing, is reflecting that the person becomes unconscious how fast. If a syncopal attack has occurred, patient has got a fainting attack. You must have seen these patients. You might have felt also that you don't go into unconscious phase immediately. You take some time, which may last from few seconds to minutes. Okay. So the duration of transition into unconsciousness, right? It's much longer in a patient of a syncopal attack. While the duration of transition into unconsciousness is very, very short in a patient of a seizure episode. So we can remember this, that the transition phase into an unconscious episode, okay, it's relatively shorter in a patient of a syncopal attack, while in a seizure episode, yes, it is, sorry, I wrote it other way around, sorry. It's a longer in duration, the transition part into an unconscious phase in a syncopal attack, while it's very short in the transition phase in a seizure episode. Now another thing, now this is the transition part. Now in a syncopal attack, if you ever seen the patient, you will not forget them that they remain unconscious for not a very longer time. They become conscious maybe in few seconds or minutes time. Why? Because when you fall down, the circulation of the blood automatically relieves because the venous returns towards the heart will improve and the cerebral perfusion will also improve. So the person becoming unconscious, that is a LOC part, is very short now. The transition may be longer, but the whole episode of loss of consciousness is very short in them. While in patients of a seizure episode, yes, they become unconscious and they are not responding to the environment for a longer duration this time. Right. Now recovery. Now the recovery is very, very important here. The recovery in patients of syncope or a syncopal attack is very fast. When they lie down on the flat on the floor or someone just lifts up the leg region, the circulation totally becomes normal and they recover very fast. While the recovery in a seizure episode is very slow. It takes time for the patient to become totally normal to the environment. Okay. So we got a transition which is longer in duration in a syncopal attack with duration of loss of consciousness may be shorter and the recovery is obviously fast in them. In a seizure episode, the transition is shorter, the duration of the loss of consciousness and the recovery is much longer than a syncopal attack. Okay, I'll come to a table also that we got with us to explain this better there. Now the question stands in a very different way. Syncope may rarely trigger an epileptic seizure. Okay, why? Because if at all in a syncopal attack there is a decrease in the blood pressure that will cause hypoxic injury in the brain, and that hypoxic injury, yes, can induce a myoclonic jerks. So that's a connecting link now, that a syncopal attack can trigger an episode of a myoclonic seizure also. Now it is known as what? Should I name this as a word convulsive syncope, a bigger, broader term? Should I name this as a subclinical seizure because I don't see the seizure happening? Should I name it as post-syncopal seizure that happened after syncope? Or should I name it as anoxic epileptic seizure? Now look at this. First of all, the syncopal attack has triggered the epileptic seizure, first of all. Remember this. Because hypoxic injury in the brain has been the main reason for the seizure to happen, and that hypoxic injury has been due to decrease in the blood pressure when the patient was in an erect posture standing for a very longer time. He might have a background history of some autonomic instability, that's why he was not able to maintain the blood pressure, and that has led on to an syncopal attack 1 and has also kind of a caused hypoxic injury in the brain. So please, your answer should be anoxic epileptic seizure because it has occurred due to anoxia as such, but it was just triggered by a syncopal attack, because during the syncopal attack we find there was a kind of a decrease in the blood pressure and finally anoxic injury. Okay, so don't mention it as convulsive syncope, it's a very bigger term. Neither a subclinical seizure, neither a post-syncopal seizure, which is a very generic term. So I'll go with the anoxic epileptic seizure, the best answer. Okay, now let's look at the quick differences between the two, seizure versus syncopal attack. Immediate precipitating factor. In a seizure episode, usually we don't have anyone, while in a syncopal attack, yes, there is emotional stress, there is a valsalva, there is a cardiac or autonomic etiology in the background most of the time. Yes. Premonitory symptoms are usually not seen in a seizure episode, while premonitory symptoms are seen like tiredness, nausea, diaphoresis in a syncopal attack. Posture at the onset. Yes, I've described this in the image also. Is variable in a seizure episode, while in a syncopal attack, it's often erect posture. Transition into unconsciousness. Yes, seizure episode is often immediate, while in a syncopal attack it's gradual over seconds. The duration is just the ulta now. The syncopal seizure episode will have the duration of loss of consciousness in minutes, while in a syncopal attack will be only for seconds. The duration of the tonic-clonic movement. Now this is important now. The duration of the tonic-clonic movement, yes, will be 30 to 60 seconds. can go into minutes also for a seizure, while in a syncopal attack it will be less than 15 seconds. Now the word tonic-clonic is already written here, but it's more likely to be a myoclonic jerky movement, okay, which can be a clonic movement also. Facial appearance, important. Seizure episode is going to show cyanosis because in the tonic phase cyanotic spells occur. Syncopal attack is due to hypoperfusion. Whenever there is a hypoperfusion, there is a hypoperfusion in the whole body also. So if you remember, there is a hypoperfusion in the conjunctiva or maybe the tongue, you're going to see what? Pallor. So syncopal attack patients might come during the episode pale and they will become red when they totally recover from it. Disorientation after the event, yes, that's important now. It might go from minutes to hours in a seizure episode, while in a syncopal attack it is usually seen to be less than 5 minutes. Aching of muscles after the event. Seizure will have a lot of aching and all because it was more vigorous a movement, while syncopal people might also complain of the same symptom, but it's not all the time present. Tongue bite, yes. Tongue bite is seen in both of them. More typically in a seizure, but can happen in a syncopal attack also. I've discussed this in the classroom also that tongue bite in patients of a seizure episode will often occur in the lateral margins because in the tonic phase we are biting the teeth, clenching the teeth, and somewhere the tongue might come in between and between the teeth, and the tongue bite is more often on the lateral margin. While in a syncopal attack the person is falling down, the tongue might protrude out, and then there is going to be biting of the tongue at the tip part more often. Urinary incontinence, again important, is seen in both of them. Some of the authors do write like, yeah, it's more common in a seizure, less common in a syncopal attack. Yes, but it's seen in both of them. Fecal incontinence, this is from the volume 1 of Harrison in the syncope chapter, that fecal incontinence is something seen in a patient of a seizure episode. It's rarely seen in a patient of syncopal attack. Headache is more common in patients of seizure, less common in a syncopal attack. So this is a table that will easily recollect. It's just a recollection of what we saw in a seizure and syncopal episode, which actually mimic each other very well. Now in a syncope, like a person is standing, he might be holding his breath or breathing very fast, that might precipitate it. Patient becomes unconscious, yes, there will be sudden jerky movement. And when the person falls down on the floor, the patient is more likely to recover very fast. Okay, so that's all about an episode of syncope versus seizure. Now going into another segment, that is the movement disorder. It's all in the image, is very simple. We've done this in the classroom also, that the person is having a typical crawling movement of the distal epilum is known as the ethitosis, right? Or maybe the person is having a typical lance-like movement like this, which is known as the chorea. And of course, maybe the person is having a typical large amplitude flinging movement of the proximal limb, maybe the upper limb, lower limb, on only one part of the body, that is known as what? The hemibellismus. The hemibellismus, right? So what is the connection part here? As you can see, this is a coronal view of the basal ganglia. If you remember, the ethitosis occurred due to lesion where? Globus pallidus. So globus pallidus you can locate over here, and whenever there is a lesion in globus pallidus, we get a movement disorder, that is the ethitosis, right? While if chorea occurred due to lesion somewhere in the caudate nucleus, right? So there was a lesion in a structure known as caudate nucleus causing chorea. And hemibellismus occurred due to lesion where? Subthalamic nucleus. So subthalamic nucleus, whenever there is a lesion on the contralateral side of the body, we are going to find the hemibellismic movement, right? So this is about the movement disorder, and this is an image which shows a patient of your Parkinson disease. As you can see, this elderly man is standing with a stoop flex posture, He might have some shakiness of his hand, that is the resting tremor. And while walking, he cannot take the step too much ahead in a single swing phase. Okay, so he got a short step gait which is ready to run most of the time, that we know as a festinating gait. The festinating gait. And of course, as you can see in the last image over here, yes, this one. When I try to pull the patient backward, he's going to fall over me because of postural instability. Yes. And what test have we done here? The pull test, the pull test. While on the other spectrum, we've got a person or Parkinson having this kind of a rigidity. Yes, there's nothing but your cog wheel, which you fit into a tire or maybe something where it rotates with a jerk in between. So this image shows a cog wheel. So rigidity is of the type cog wheel. The tremors of the type resting. The person is very slow in walking, that is bradykinesia, with a short stepping gait, festinating, and of course a stoop flex posture, right? Okay, now let's see this one. Just a second. Yeah, got the images here and I've got the videos also with me. Like a person with acetosis will have this limb moving like this, that's a crawling movement. Korea, of course, will have a typical dance-like movement like this. Oh my god. Stop. Hemibilismus is having a typical jerk-like movement like this. Right. Stop. And of course, your patient of Parkinson disease is going to walk with a stool flex posture like this. And with the terminal part, with the end part, he is going to fall on the obstacle itself, that is a postural instability. Now moving into the another spectrum, that is a tremor that we see. Yes, these tremors are describing the whole event. It's very simple. Here on the left side, this is nothing but a round tremor like this. If you remember, this one is the resting tremor that we find. The resting tremor, which occurred in patients of Parkinson disease. Then we have another tremor where the hand is held like this, the negative myoclonus. That is a flapping tremor, like the flap of the wings of the bird, which occurred in most of the encephalopathies. Then there are two tremors which are slightly different. I'm trying to put my finger on my nose and then direct it to the finger of the patient. And suddenly on reaching the patient's finger, my hand starts shaking. On reaching the target, my hand starts shaking is known as what? The intentional tremor, right? While the tremor is same throughout from the beginning till the end. Yes, that is what? Your essential tremor. If you remember a tremor which increase on anxiety, decrease on taking alcohol with a family history, autosomal dominant trait, was an essential tremor. And that tremor remained the same, it did not increase in intensity on beginning or the end part, okay? So that was an essential tremor. Intentional tremor, if you remember, happened in a cerebellar lesion. Okay, let me just show these tremors to you in a videographic image also. The person is having a resting tremor and is shaking like this. Catching a mobile phone, talking on it, the tremor typically disappears. Stop. Flapping tremor is a flap which occurred all the time like this. Okay. Intentional tremor, which happened on the hand reaching a particular target intentionally. Right. Stop. Now we've got another image that is regarding the gait. A person who is walking normally like this. It's a normal person walking like you and me. And this time this person is walking with a stooped and a flexed posture, with the steps not taking too much far away from each other. So in the typical swing phase of the gait cycle, when I take my leg, I can take it comfortably to a longer distance. But this time the distance in the swing phase being covered is very less. So this is the short stepping gait, as if the person was ready to run somewhere, known as the festinating gait. And the festinating gait happened in patients of what? Parkinson disease. Don't forget that. Now there's something which mimics a fascinating gait in the lower limb. Again, the short stepping gait. Person takes a short steps. Yes. But look at this now, please. The person is able to lift his leg up from the ground very well as compared to a patient of Parkinson 1. And the second most important thing, in a Parkinson, the hand was not moving at all. Because of the rigidity in bradykinesia, the arm swing did not occur. But this time the arm swing is really very good. So this is a patient who is having a short step gait. Short step gait. Yes, one thing. With a good arm swing, good arm swing. You know, if you've seen soldiers on a march pass when they are in a parade, they walk exactly like this. They don't take the steps too much far away. They take shorter steps, and most important, when they move, they take the arms very well. Okay, so this is known in a French terminology as a marche a petit pas. Marche a petit pas. So something, the word petit comes again, which is basically meaning small, you know, like petit mal epilepsy happened in absence seizure. So there are legs which are moving not too much ahead, they are taking shorter steps, which is in French known as the word petit, and they're walking like a soldier, you know, marche a petit pas, right? So somewhere we find it in the books, like, you know, the frontal lobe lesions, somewhere the frontal lobe lesions often show these kind of a gait disorder known as the marche a petit pas. And this one is quite simple. You can easily tell me what it is. Yes, the person is lifting his foot from the ground. He's got excellent ground clearance, one thing. And he cannot really dorsiflex the foot whenever he's lifting his leg above from the ground. And now when he puts it down on the floor, he just bangs there. It's not a stamping gait, my dear friend. It's not a stamping gait. In a stamping gait, you don't lift the foot above the ground so very well. Okay. So this is nothing but your high steppage gait. Yes, the high steppage gait. If you remember this topic, this gait happened in patients of foot drop. In patients of foot drop, this all happened. Or maybe a case of peroneal nerve injury. Yes, that was a cause of foot drop. Then we have this one, in which the person is trying to stabilize his leg on the floor and trying to rotate the leg like this, making a half circle while walking. Yes, that's the circumduction gait. Making a half circle every time he's walking. The circumduction gait. So that's simple, that's easy, no problems in this. And that happened in a corticospinal tract injury, which occurred more often in patients of stroke. Yes. Now, let me just show you a videographic representation of them, like marche a petit pas. Here my foot went up, I took shorter steps, and most important, there was the forearm movement was very good, like the marching head of the soldier happened. The high steppage, we find that the person is taking his foot high above the ground because the person is having foot drop. Okay. And of course the circumduction gait, making a half circle every time while he is walking, which happened in patients of stroke. Right. Okay. Now we have an image which shows various areas being numbered, and we have to locate which area is it and what could be a neurological deficit if something wrong happened in that particular zone. So there are two sections, one is a lateral view of the brain and one is a medial view of the brain, and some easy question attached to that. Now let's look at this. If you remember this particular zone, yes, is the frontal lobe. Yes, the frontal lobe, and this wala hole becomes your parietal lobe, and this could be the temporal lobe, and the occipital lobe at the back. So these are the four basic lobes, and what are the areas located in them? Let me start with the frontal lobe first. Frontal cortex of the frontal lobe. Now like this, area number, right, and its particular name, right, and if at all there was a lesion at this particular zone, okay, what could be a particular deficit. So we have done this also in the classroom, but I'm not intentionally use the word area numbers, because you do all this stuff in more than anatomy. Let me connect this in neurology now. So we've got anatomy, we've got a physiology, and then we have got a deficit. Now area number four, yes, the first one, area number 4. What is it known as? Primary. It is known as what? It is known as your primary motor area. Okay, and if at all there was a lesion in this primary motor area, what did we see? We saw what? We saw hemiparesis. One side of the body got weak, of course the contralateral side. Correct? Now area number 6. Just in front of 4 we got area number 6 in the frontal lobe, which is what? Premotor area, which was trying to define sort of a movement and give it more accuracy while doing with the help of the extrapyramidal tract. Okay, premotor area. Now number 8. Number 8, yes, was your frontal eye field. Yes, remember number 8, frontal eye field. And if there was a lesion at this point, it's known as a conjugate gaze palsy which occurred in the patient. And if you remember this, we got a question on this also. There was a lesion that was destructive, the eyeballs deviated towards the lesion. There was a lesion irritative, the eyeballs moved away from the lesion. Okay, conjugate gaze palsy. And most important, which helps me to talk every time, is area number 44 and 45. Yes, that is what? The famous Broca's area. And you know this, that Broca's area, if there is a lesion that we find aphasia where the fluency is impaired, okay, that's known as the Broca's aphasia. Right. Now if I try to look into the medial side, there's an area number 9, 10 and 11. This lies in the frontal lobe in the interior part. But it can be. Any ideas on this? It could be a prefrontal area. Yes. The area number 9, 10 and 11 not described in all the textbook, which 9, 10 and 11 is your prefrontal area. And if at all there is a lesion in the prefrontal area, what do we find? We find something wrong in the personality of the patient. That means the person has got some kind of a behavioral abnormality. So I am showing this image and connecting the dots because in most of the MCQs you might find an image being marked like area number 44, 45, they will put a cross over there and then ask you what could be the neurological deficit in the patient, right? Now we see the parietal cortex or the parietal lobe. Parietal cortex, parietal lobe. In the parietal lobe, we got the area number 312. Okay, if you remember, we had what? The primary sensory area sitting over there. There could be loss of localization or can be a sensory loss if there was a lesion in this part. So the basic outcome will be kind of anesthesia seen in the patient to some modalities of sensation if there was a lesion in the parietal lobe. Then we have the area number 5 and 7, right? That was the sensory association area. Sensory association area seen in the patient. Correct? Now the sensory association area, there is a lesion over there, then we find a problem in judging the shape, judging the object on touching, that is astereognosis or graphisthesia, if you remember, and difficulty in your 2-point discrimination even. Okay, so area number 5 and 7 in the parietal cortex. So the parietal cortex is more of a sensory cortex. The 312 is the primary sensory cortex and 5 and 7 is a sensory association area. Now let's go to the temporal. You like the temporal over here. Okay. Temporal cortex. 39 and 40 and 22 also. Okay, and like this, 22 more than 39 and 40. Why? Because there has been a controversy of late on this, that the Wernicke's area, that is for comprehension, is located where? Some of the authors write it as 3940, some of the European authors put it as 22, but 22 answer is better than 39 and 40. Actually, the Wernicke's area is an extended area. It starts from 3940 and go to 22, but it starts in 22 and go to 3940. So remember this, the better answer any time is going to be the area number 22 in them. Now this particular temporal lobe, we got a Wernicke's area, and the Wernicke's area, if there is a lesion over there, we get a problem in comprehension, that is a Wernicke's aphasia. But just to point to revise over here, area number 22 has got another work to do. It is also known as the secondary auditory area. Some of the authors have described the area number 22 as the secondary auditory area also. Okay, secondary auditory area, area number 22. Right. Now, where is the primary auditory area? If area number 22, I describe it as the secondary auditory area. Where is your primary auditory area? Let us look into the medial side. Okay, it's not been mentioned over here. The area number 41 and 42. Area number 41 and 42 is your primary auditory area. Okay, primary auditory area. Another very important thing on the medial aspect you might see into the temporal lobe is this 23 and 24. It can extend into the frontal part also. 23 and 24, yes, if you remember, is a part which is important for the memory circuit, emotions, everything. A part of the limbic system which I can include into as a cingulate gyrus. There are a lot of functions done which you learn in physiology on the cingulate gyrus, area number 23 and 24. And what is area number 28 doing over here on the medial aspect of the temporal lobe now? Area number 28. That's for smell. Yes, that's your primary olfactory area. Primary olfactory area. Area number 28. So a quick recap of everything again, like the area number 4 happened to be the primary motor area. Yes. The area number 6 is the premotor area. The area number 8 in the frontal lobe happened to be the frontal eye field. The 9, 10, 11 went on to the prefrontal group. Maybe on the lateral aspect of the frontal lobe, 44 and 45, yes, is the Broca's area. Now something which is swinging between the temporal and the frontal and the medial aspect is 23 and 24, that is the cingulate gyrus. Area number 312, yes, in the parietal cortex is the primary sensory area, while just behind it in the lateral aspect 5 and 7 is the sensory association area. Wernicke's area is in the temporal lobe, again, yes, in the superior temporal gyrus, but one answer, the best answer is area number 22. More than 40 and 39, but it's an extended area, goes like this, while area number 22 is also known as the secondary auditory area. Primary auditory area is area number 41 and 42. Okay, and area number 28 is for olfaction, primary olfactory area. Now occipital is simple. We got an area number 17. Yes, that's a primary visual area. 19 and 18 together, yes, is a visual association area. So primary visual area is area number 17, 18 and 19 is an association area for vision. Okay, so that's a quick recap of what we saw. In anatomy and into neurology, we should know what can be the particular deficit here. Now this question is simple. Which of the following has the maximum area of representation in the cerebral motor cortex? If you remember the homunculus, maybe a coronal section being made in which the whole body has been represented. The lower limb happened to be sitting in the paracentral lobule, the medialmost part, trunk, arm, forearm, and then you have the big hand, and maybe the laterally the face, or could be a tongue, and even the laryngeal inlet. Now if you look at this, looking at every joint, shoulder, elbow, wrist, and the first metacarpophalangeal joint, we learned this in the class, and you know it from physiology also, that finer the skill, larger is the area of representation. So you do fine skill with your fingers, and finger moved by the help of a joint, that is a metacarpophalangeal joint. So if at all, one area out of all which would have the maximum representation in the cerebral motor cortex has to be the metacarpophalangeal joint, okay, to do the fine skillful activity by the fingers, right? Now this is an image from opthal. If I see the connection of the sixth with the third cranial nerve, sixth cranial nerve which is abducting the eyeball with the help of lateral rectus, and the third which is abducting the eyeball with the help of medial rectus. Sixth and the third, the sixth nucleus was sitting where? In the pons. Third nucleus was sitting where? In the midbrain. Both of them are connected by the help of what? Yes, a fascicle which moves longitudinally like this, crosses the midline also, the medial longitudinal fascicle. Now what has happened in this particular case? Look at this, there is a good connection of the sixth cranial nerve on this side. That's why the eyeball is able to abduct. And there's a connection here with the opposite contralateral eyeball. Because of that, the eyeballs can abduct, right? So MLF of this side is intact. Well, MLF of this side has gone. If MLF of this side has gone, the connection of the sixth on this side and the third of the opposite side will be lost. So what can be the deficit? Look at this now. Sixth here, yes, will work and abduct the eyeball. But the third on the opposite side will not get the signal from here, right? Because of this, there is no abduction of the eyeball seen this time. So this eye will abduct by getting a continuous signal from the frontal eye field, and this continuous signal will induce a jerky movement on the lateral gaze known as the nystagmus. So in this patient, there is nystagmus in the abducting eye, and there is fair reduction of the opposite eye because the lesion is in the medial longitudinal fascicle, and the lesion is somewhere between the nucleus of the two cranial nerves, sixth and the third. So we also name this as what? Internuclear ophthalmoplegia. Sorry. Eyeballs cannot move and the lesion is between the nucleus. Internuclear ophthalmoplegia, right? INO. Now this is something which is being dealt in the class. I need not revise it. I'll just recollect everything what we have done. Like, there was a lesion that was irritative in the cortex. The eyeball moved away from the lesion, and this lesion was in the frontal eye field. Yes. So if at all the patient had a brain tumor on the right cortex, the left half of the body will have the seizure activity and the eyeballs will move away from the lesion. While on the other spectrum, if the patient had a lesion in the frontal eye field this time, and that was a destructive lesion like an infarct, again the patient will have contralateral hemiparesis, but this time the eyeballs will move towards the lesion. Okay. Let me connect this image with a very simple question. Patient develops left hemiparesis with a lesion in the frontal eye field. Look at this again. Patient develops a left hemiparesis. Yes, hemiparesis as a disorder often happens due to a destructive lesion in the cortex. Yes, infarction or something. Because of that, the frontal eye field has also got destructed in the patient. The eyeballs will move where? If the lesion was in the right cortex, the eyeball will move towards the right side of the patient. Okay. So patient develops left hemiparesis with a lesion in the frontal eye field. The eyeballs will move towards the right side. Simple. Now this is something that we've discussed in the class also. Yes, there is a connection between the auditory and the visual cortex with the Wernicke's area, which is taking the signal to the Broca's with the help of what? The arcuate fibers. Now, patient with aphasia has impaired comprehension but for spoken word, impaired repetition but has preserved naming and fluent speech. Look at this please. Patient has preserved naming and a fluent speech, has impaired comprehension for a spoken word and impaired repetition. Where is the lesion lying? It's lying in B. You know why? Because if you remember, we've discussed this in the class. Sorry, it's lying in A. I'm wrong in this, sorry. Now, what has happened in this case, when the person is seeing an object, he's seeing it through the visual cortex. He understands it in the Wernicke's area, he makes the word in the Broca's area. And the connection of the Wernicke's and the Broca's with the help of arcuate fiber is intact. So naming is intact in the case. His Broca's area is intact, so his fluency is intact. But what about comprehension? Whenever I'm telling a command to the patient to follow, like show me your tongue, raise your hand, the person listens to me in the auditory cortex. So the comprehension, see, the input comes into the auditory cortex. I understand it in the Wernicke's area and I do a particular command, right? While on the other spectrum, repetition also follows the same circuit. I tell my patient to repeat with me one. He listens to me one, he understands one, and he speaks one. But that listening and understanding has to go through this A. Now, if there is a lesion in this part A, the connection of the auditory cortex and Wernicke's is lost. So what do we see in this case? Person can hear my word but cannot understand my word. So he's basically deaf to words, known as the pure word deafness. Pure word deafness. Correct? Pure word deafness. That happens in patients of aphasia. Okay, when the lesion is at the structure A. What are the other kinds of aphasia? Let's quickly revise them in a very quick go. Wernicke's aphasia, there was a lesion in the Wernicke's area. What happened with the patient? His comprehension is impaired. He cannot understand. Since the patient cannot understand, he cannot repeat. When he cannot understand, he cannot name an object, but that patient can speak. So his fluency is preserved or might increase also. In a Broca's aphasia on the other spectrum, his Broca's area word forming zone has got involved, so the fluency is decreased. Because he cannot speak, he cannot name a particular object. Since the patient cannot form the word, he cannot repeat, but he can understand my command. So his comprehension is preserved. In a global aphasia, as you can see, Wernicke's and Broca's both are involved. So neither understand, neither repeat, neither name, neither speak. Total silent movie. Conduction aphasia. Yes, there is a problem in conduction between the Wernicke's and the Broca's area. Since the patient can understand my command, his comprehension is preserved. Since the patient can make his word, his fluency is preserved. But his repetition and naming is totally impaired. Okay, I'll just change the coloring scheme. So his repetition and naming is totally impaired this time, while his ability to speak and understand is preserved. Okay, because Wernicke's and Broca's are individually normal, but the connection is lost. Then transcortical motor aphasia. Just remember this way, that they are the brothers and sisters of Wernicke's and Broca's with preserved what? Repetition. So in both of them, they have a preserved repetition. See, in transcortical motor aphasia this time, there is a connection with a Broca's aphasia. That means they are like Broca's patient. So in Broca's, if you remember, the fluency was impaired, the naming was impaired, but comprehension was preserved. Transcortical sensory is like Wernicke's with preserved repetition. In Wernicke's, we have seen just now, the comprehension was impaired, the naming was impaired, but the fluency was increased or preserved. So transcortical motor is like Broca's, transcortical sensory is like Wernicke's with preserved repetition. Then we have the mixed isolation aphasia, that is transcortical mix. If you mix the two, we find that in the patient they have a preserved repetition, while rest of the things are totally gone. Right? Anomic, simple. The only one problem in their life for naming. Rest all is well in anomic aphasia patients. Pure word deafness, in the question that we have seen, they're impaired only for the spoken language. Yes. Okay. So if they have impairment in understanding a spoken language, obviously the repetition will be impaired in them. While the naming which happens to the visual pathway is preserved and the Broca's area is working, so the fluency is also preserved. Purelexia is pure word blindness this time. The person is only blind to words. So this time we find in them that their comprehension is impaired only for reading. Rest all is well in them. So this is an actual description of various kinds of aphasia in a simple table. Now this is something that you know from anatomy, a description of the blood supply of the brain. Now the pink wala is what? An artery which is the anterior cerebral artery. If you remember, this anterior cerebral artery supplies a strip across the frontal lobe like this, anterior to posterior end, and also the medial part of the frontal lobe. Okay, the major medial part of the frontal lobe is supplied, or even the whole cortex is supplied by the AC. While the major part in the lateral view and even the inferior view is supplied by this blue. What is this? The middle cerebral artery. And what are we left with? The yellow one. Yes, that supplies the posterior part. Okay, even the medial part of the brain, that is the posterior cerebral artery. So this is nothing but your blood supply of the brain. Now here's a question which is slightly tricky. Elderly male suffers a stroke that appears to involve the left internal capsule rather than the cerebral cortex. It results in paralysis of the right arm and the leg. The tongue deviates to the right side is lost. His speech is slurred and fluent and grammatically correct. What kind of speech deficit the person is suffering with? See, first of all, the lesion is not in the cortex. Remember this. Whenever there is a lesion in the cortex, in the patient we get what? Aphasia, which can be Wernicke's, which can be Broca's, conduction, anomic, anything. But if at all there is a lesion below the cortex, like for example in this case the lesion is sitting somewhere in the internal capsule or even the bulb of the brain, medulla, yes, if at all there is a lesion in medulla or maybe the internal capsule, then in that case we have got difficulty in articulation of speech seen, dysarthria. Why? Because when the Broca's area has developed a particular signal, that signal has to come down. And that particular signal which comes down comes through the corticobulbar tract, not the corticospinal. That ends in medulla and sends the signal to the tongue muscle. So look at this question again. The tongue muscles are weak. Maybe the corticobulbar fibers in the internal capsules are involved for the tongue, which has got the problem in a term like slurring of speech, which is fluent and grammatically correct. That means the Broca's area is perfectly normal. And above all, the person has suffered a stroke with no lesion in the cortex. So don't brand it him as a case of aphasia. Okay. And if at all you know this, if there is a lesion somewhere below in the voice apparatus, that is the larynx of the patient, yes, what do we get? Dysphonia. So difficulty in phonation, difficulty in articulation, difficulty in word production or understanding, all the things combined like this. So this particular question is, the answer is dysarthria. Now this is an image which shows the particular involvement of various areas of the brain as per the infarct that we see. Now this happens to be an infarct which involves the middle cerebral artery or the MCA. And look at this, we are involving the entire territory of the MCA. Because there is an infarction because of that, with a lot of area involving the lateral parts of the cortex as well as the medial part like this. In a coronal view you can see. Now remember this, if there is an infarction in the MCA, the entire cortex, we get what? Contralateral hemiparesis. Contralateral hemiparesis. And above all, don't forget, if it is involving the left side, yes, if it is involving the left side of the cortex, this particular infarction, then in that case, the superior as well as the inferior division of the MCA are involved. If you remember, we discussed in the class, superior division supplies the Broca's area, the inferior division supplies the Wernicke's area. So now what happens? If there's a lesion on the left side of the MCA, the entire territory, you get what? Global aphasia, where the Wernicke's and Broca's both are dead. Okay. Now this time we have got an image where we have the involvement of this area also. Now just a revision of something that you should know from anatomy. These are the branches of the MCA which are sending the blood deep into the brain, the lenticulostriate branches, yes, which supply the basal ganglia part and thalamus region also. Now if at all they are supplying these particular branches known as the lenticulostriate branches, if at all they are involved in the entire infarction of the MCA, the entire territory of it, one more deficit in the patient might see. Because as I told you, they supply the thalamus, which is a part of the basal ganglia functionally. Thalamus. Now, if at all there is a lesion in thalamus, what do you get? Contralateral hemianesthesia. Contralateral hemianesthesia in the case. Right. Now, please follow this. If at all there is a lesion in the superior division of MCA, first of all, look at this diagram. Superior division of MCA is involved. A lot of the part of the brain is involved. The frontal cortex is involved. Okay, the temporal lobe, and in the coronal view also we can see. So one thing is clear in these patients. Remember this: the superior division of MCA. The superior division of MCA supplies what? It supplies two parts. One is the frontal lobe, and the second one is the parietal cortex also. It supplies the frontal as well as the parietal cortex both. Now if at all the superior division of MCA is involved, the frontal lobe is involved. If the frontal lobe is involved, we're going to have contralateral hemiparesis. One thing. And if you remember, the frontal lobe had the house for the Broca's area number 44-45 in the inferior frontal iris. So if the lesion is on the left side of the brain, involving the superior division of MCA, the dominant side, we get which aphasia? The Broca's aphasia. The Broca's aphasia. And one more additional point, the parietal cortex was my sensory cortex. Yes. So we're going to have one more thing in the patient. Yes, what? Hemianesthesia. Now this hemianesthesia this time occurred due to lesion in the parietal cortex. Parietal cortex. Correct. Now the inferior division. Next one is the inferior division. The inferior division of MCA supplies which part of the brain? Now in the diagram it's very clear. Does it supply the frontal lobe? Does it supply the frontal lobe? No. So what does it supply? Look at this diagram please. It supplies the temporal and a part of parietal also. So it most of the time supplies the temporal lobe and just a part of the parietal cortex. So if the frontal lobe is not involved in an inferior division of MCA, do you expect a hemiparesis to occur? No. Remember this quick point. Hemiparesis is not a symptom when the lesion is in the inferior division of MCA. So I can put a minus over here. Hemiparesis is not seen. But as I told you, it involves parietal also, inferior division. So if the parietal cortex is involved, what are we going to see? Hemianesthesia. Right. If at all the lesion is involving the left side, the dominant side, and the superior temporal gyrus is involved, which aphasia are we going to see? Yes, the Wernicke's aphasia. So superior division, the inferior division, and the entire division of MCA. Okay, some of the authors have put like this, M1 and M2 syndromes, where the M1 word comes here, the word M1 comes here, where the entire division is involved, while the M2 wala will come distal to that, which can be the involvement of the superior or the inferior division. But that nomenclature is not well accepted everywhere. Okay, so that's why I'm trying to skip every time that particular word M1, M2. Now same goes for the ACA. Now this artery is the anterior artery in the circle of Willis. Okay, now the anterior artery, is of two types. If you can see in a simple diagram like this, the ICA comes and bifurcates itself into ACA and MCA. Yes, the ICA comes and bifurcates itself into ACA and MCA. MCA further bifurcates itself into the superior as well as the inferior division like this. And don't forget, this ACA is communicating with each other on the either side with the help of anterior communicating artery, right? Now I have got a lesion in a segment of ACA which is A1 or maybe A2. What is this A1 and A2? As you can see, A1 wala is pre-communal, that is before it meets the communicating artery, while A2 wala is after it has met the communicating artery, known as the post-communal. Right? Now what is the thing and the concept behind this? If at all there is an infarction, like you remember this thing, infarcts which happen in the brain, that is ischemic strokes, most of the time are embolic, not thrombotic, embolic. So embolism, if you remember, is the most common cause of embolic strokes every time, and most of the strokes that we find are embolic. Now this thrombus embolus has come in the ACA territory in the A1 segment, that is pre-communal. We have discussed this in the class. Will any kind of neurological deficit occur in the case? No. Why? Because the contralateral side will reperfuse that particular brain part which has got a deficient blood supply because of this particular embolus, right? So TIA will occur. That means a person will have an ischemic attack and the patient will recover very fast. While if the lesion is post-communal, that is beyond the communicating artery, even the reperfusion from the contralateral side cannot help the patient because this thrombus has now lodged into this part. Okay, and now even if I try to reperfuse it from this end, it is not going to easily dislodge from that particular site. So A2, post-communal ACA territory artery infarcts. Although in this image it looks like pre-communal in this wala, don't worry, but if at all there is a post-communal or A2 ACA infarct, what could be the deficit? Look at the medial part of the brain. The medial part in the coronal section, this particular zone is supplied by ACA. If you can connect the dots, yes, it is the paracentral lobule, the motor cortex in the homunculus. So if at all there is a lesion at this point, we find what? Contralateral lower limb weakness in the case. One, because the motor cortex of the lower limb is the paracentral lobule. Second thing, if you remember, for the paracentral lobule, one major function it used to perform is controlling the bladder socially. So urinary incontinence occurred in the patient. Okay, and don't forget ACA also supplies the prefrontal area, the 9, 10, 11 wala. And if at all there is a lesion over there, what do we get? Antisocial behavior. So post-communal, that is beyond the communicating artery, if there is an ACA infarction, this could be the neurological deficit, right? Now this image is an image of circular villus, simple image. You can see circular villus and you can find an aneurysm in any point in them. It can occur at the ACA, anterior communicating artery junction, the posterior communicating ICA junction, the vertebro-basilar junction, or maybe the basilar bifurcation into the PCA, right? And if you remember in the classroom, we have discussed that most of the aneurysms are interior. So most common site of the aneurysm to happen is ACA and anterior communicating artery junction. Okay. Now look at the question please. 25-year-old hypertensive male presents with visual field defects followed by sudden onset headache. Now first of all, remember this. There is always a prodromal symptom that we have discussed in the classroom also, which can occur prior to the onset of rupture. Visual field defects are something which happen when the lesion is somewhere near the optic chiasma or maybe the optic part of the brain. Now this particular zone lies over there. So if there is a lesion in anterior communicating AC junction, very often we find a prodromal symptom like visual field defect. And something in radiology sir has taught you, if there is blood in the septum pellucidum, the anterior again, then the aneurysm is most likely located in the anterior circulation at this point. Just a quick recap. If at all there is an aneurysm at B, that is posterior communicating IC junction, what do we get? We have discussed this in the class. We find in the patient a typical pain that is retroorbital pain, with of course one thing very important, a cranial nerve palsy, third nerve palsy, right? If at all the lesion is somewhere at C or even at D, that is a vertebro-basilar junction or maybe the basilar bifurcation, we often find in the patient occipital pain, a typical throbbing pain in the neck region of the occipital lobe we can see. Just another quick point here, if the lesion aneurysm was at the MCA bifurcation, then what happened? Then in that case we find a typical temporal pain, which is a throbbing pain, because you know aneurysms are expanding with blood and then recoiling when the blood goes away from them. So the typical temporal pain will occur if the aneurysm is at the MCA bifurcation. So anyway, for this question the answer is very clear, very easy. The lesion is most likely at the anterior communicating and AC junction, right? Now this is another question that we have discussed in the classroom, and this is an image which shows what? Concavo-convex opacity, that is a subdural hemorrhage, SDH. And look at the question. 62-year-old diabetic patient presents with history of progressive right side weakness of 1 month duration, kept on increasing for a month. Fundus examination shows papilledema, raised ICT. 2 months ago she had a fall in a bathroom and struck it against the wall. Now 2 months back she had a history of fall, and for the last 1 month her weakness is progressively increasing. And this particular SDH is causing raised ICT in the case, and the raised ICT could be seen in the fundus examination in form of papilledema. So the best answer is left chronic subdural hematoma, right? Now another simple question. A 45-year-old male presents with left arm clumsiness. Physical examination reveals a motor weakness with increased tone of the left arm. Specifically with the passive extension of the left arm, there is initial resistance, then a sudden release occurred in the extension when maximum extension is reached. Now looking at these words, what do you find? I'll repeat it again. On the passive extension of the left arm, there is initial resistance and sudden release when the maximum extension is reached. What is this? A clasp knife kind of a rigidity. Yes. So my patient has got a motor weakness with a clasp knife rigidity. Okay. Now remember, this clasp knife rigidity also unidirectional, is known as spasticity. Now it is a lesion in the corticospinal tract. Now in this diagram, it's a section of the coronal view of the brain in which we find various structures lined up. Okay, now let's see what is this structure. The peripheral outer part of the lentiform nucleus known as what? The putamen. Right. Now D and E, both of them are the part which are external and internal of what? Globus pallidus. A is the head of the nucleus, caudate nucleus. And what is B? B is an area which is sandwiched between lentiform nucleus and maybe a thalamus on this side. Maybe a thalamus on this side. What is this? B. B is nothing but your internal capsule. So whenever there is a lesion in internal capsule, the corticospinal tract fibers are involved, resulting in this kind of a human kind of a weakness. Now the common doubt which might come into your mind immediately, wait a minute sir, you taught us in the classroom that hemorrhagic stroke which occurred in a hypertensive intracerebral bleed, the most common site was putamen, and putamen bleed presented in form of a contralateral hemiparesis. So why not? The answer is putamen. First of all, my dear friend, remember this one. In a bleed which is intracerebral bleed and it is a hypertensive bleed, remember the examiner will always give you a background history of hypertension, quick deterioration in the level of consciousness and everything. Not as a simple question like this. So if you want to mark one answer, best answer, safe answer, go with B, not with putamen, right? Now let's look into this one. A family consists of a husband, wife and children. Wife's father has got Huntington's chorea, right? Now family consists of husband, wife and children, this one. And wife's father is suffering with Huntington's chorea. Which of the following statement is true about the case? We have already done this question in the class. Let's revise it fast. Like if one of the parent is affected, then in the subsequent generation the chance of getting the disease is 1:2. If mother gets affected, then again in the subsequent generation, the chance becomes 1:2, not 1:4 any time. Can occur up till age of 50, that's again a partially correct statement because the common onset of the disease Huntington is in a bracket of 25 to 45 years. Now if the wife does not get the disease till age of 50, her children are not affected. That's very correct statement. Because the upper limit to get the disease is 50. Now if in case her brother or maybe some other brother gets affected, then in that case her family is not affected. So the upper limit to have the disease could be taken as 50 for the onset. Now if she's not affected, her children are not affected, yes, because her siblings got affected by the disease, because this disorder follows the autosomal dominant trait of inheritance. So that's a better answer than B. C and B both are correct, but C is better than B. Now Huntington chorea is due to point mutation in the gene. No, that's not a very correct statement. It is an autosomal dominant disorder which occurs due to trinucleotide repeat sequence defect of CAG repeats. Yes. Now these are few images which are pertaining to patients of headache, right? Now look at this one first. In this image we can see a person lying down on the bed with an arrow marked over here. That means this patient is having a problem in the neck region, that is neck rigidity. And when the headache actually happened, he felt the worst headache of his life. As someone has hit him from behind, maybe a thunderbolt or maybe a baseball bat like this. So this kind of a headache has been described by the patient, never ever experienced previously a typical thunderclap headache. Now another thing, if you are hit by a baseball bat like this on the head region, obviously at the time of impact the headache will go maximum and then it will die down like this. So that is a severity of headache which happens. Maybe if I take the plot for minutes and maybe hours, I find the headache is maximum at the time of the onset of the headache, and then it dies down gradually. So this is nothing but a case of your subarachnoid hemorrhage, right? So in this image we have tried to include a disorder, subarachnoid hemorrhage, like this. Now the second image is this, in which maybe over minutes and hours the headache has kept on increasing like this, and again an arrow here and an arrow here. So there are two arrows. Now this arrow is again for neck rigidity, and somewhere on the flexion of the hip the pain increases. Yes, the Brzezinski sign, the Kerning sign, where you find the pain increases on flexion of the hip or the neck region because of the continuous meningeal inflammation. And of course the dots like this, the arrows like this. So it basically reflects that the headache is generalized, and the patient has come to me with neck rigidity, and on flexion of the hip, knee, or maybe even the neck region, the pain rises. And the headache is not maximum at the onset. It gradually increases like this. So this is nothing but a sorry, a sign of meningeal inflammation due to an infective pathology, that is meningitis. Right? Now the third one is a elderly male who has come to us with a staggering pain like this. It kept on increases, and there were intermittent episodes of increased pain, and then it slightly subsided again in increases. And in this patient, arrows again pointing towards the leg, the shoulder joint. That means it's got a lot of pain with tenderness at various points in the body, and especially the pain is more onto this scalp region. Even the pain was seen in the jaw region, yes, and the pain was more severe in the temporal region. So this is nothing but an image which depicts a patient with a disorder where there is inflammation all across the body. It can be a polymyalgia rheumatica, yes, but the pain is more localized in the temporal region, and pain on chewing the food in the jaw region. Yes, you are quite near to the diagnosis. This is nothing but a case of temporal arteritis. So giant cell or temporal arteritis typically presents in this kind of a picture. And looking at this elderly patient, if you remember, this disease was more common in elderly. But yeah, although the image shows a male, it can happen more frequently. It actually happens more frequently in females. Now look at this female patient who has got a generalized pain. The pain actually increases on a lying down posture. When the person lies supine, the female lies supine, actually the pain in a head region increases. But in the upright posture, that is standing posture, the pain decreases. Young female, although she doesn't look obese in the image, has got a headache which increases in a supine posture, decreases in an upright posture, and with times we found the headache kept on increasing in the case. Yes, this is a case of a raised ICT. Remember this, in raised ICT, when the person lies down flat on the bed, the pain rises. When the person gets up, the pain actually might decrease. And apart from this, the pain is more generalized like this. One more thing, extra point. A female who can be young, can be obese, can harbor this problem. Remember this, pseudotumor cerebri. So what we learned here, that the raised ICT patients have got a pain which actually increases on the lying down posture, and it decreases on getting standing straight. And the pain increases with time. It will be seen in patients of pseudotumor cerebri, a raised ICT picture, right? Then we have, these were the all secondary headache. Now we got into the primary headaches. Now we got a female who's got a pain which is around the eye like this, can be periorbital, can be occipital also, and the pain curve follows like this. It is a parabolic curve. The pain increases and dies down. Might be in a time span, if I take it in 72 hours, the pain decreases, and these all straight lines are basically representing the headache, the frequency of headache. Now we found in this female patient that the pain happened like this. It was one day very severe as compared to the previous one, and then next episode it wasn't that severe. Then she had again intermittent episodes, and then the pain this. So pain keeps on recurring in her, and she is having a pain which involves a particular part on one side only. So look at this, this could be a throbbing pain or a headache in a female, which could happen on one side. Following this parabolic curve, duration is 4 to 72 hours. in a female patient, and the headache was periodic. It kept on happening until she got the right treatment for prophylaxis. Yes, now we have somewhere near the diagnosis of what? Migraine. Although this picture doesn't represent migraine so well because she's got photophobia, she could have nausea, everything, but still looking at the periodicity of the headache and the duration of headache, how long did it happen, it could be taken as a case of migraine. Now this is a male patient this time, and he's got a pain which is almost there constantly. But it happened over days, weeks, months, and it kept on going like this. And he all the time felt a lot of heaviness on his head region. Someone has placed a lot of weight on his head region, and that particular thing happened to cause a pain in a fashion like this, a typical band-like sensation. Yes, but near to the diagnosis, a typical band-like sensation with a constant headache like this could happen in a patient with depression. Yes, headache. Although the image shows a male patient, if you don't forget that this problem is more frequent in the female patient, right? Tension headache. Now we got a male patient this time whose headache was very severe again at the onset, and in very short time it died down like this. So he had a very typical periorbital pain again, periorbital pain, which was, I can write the word explosive to explain that it was maximum at the onset and it died down like a bomb, you know, it explodes and then it goes away. And there were attacks which happened like this together, and there was a time span of many years or maybe 1 year we can take in which the patient did not have any headache. Yes, so this is a classical description of what? A cluster headache, in which the pain occurred regularly in a time span, and then there was a big time where there was no headache at all in the patient. So attacks occurred in clusters. So the word applied here is a cluster headache, right? Now another one is this, a female patient who comes to us with a typical pain. Again, look at this, you know, I can think it to be a very sharp pain at the onset and it died down sharply or acutely, and there were intermittent episodes which are again together. Now look at this. This time the pain was there in a cluster and then there was a big gap in which nothing happened, but this time the gap is not that big. I can think about it as a cluster, but you know what happened was the gap between the two episodes was very short, not very long as a cluster headache. And shown with this arrow, yes, the pain was very typical in the maxillary region like this. A typical shooting pain, which increases on touch or maybe a cold stimulus, and it was again recurrent, is nothing but a typical pain of what? Trigeminal neuralgia. Trigeminal neuralgia. So don't forget, this is a typical image which I can explain the trigeminal neuralgic pain, in which the pain happened in a typical jibes. That means it was a typical shooting pain happening for a very short duration, and it was very recurrent. There was not too much of gap between the two episodes, and it typically increases on touching the face region or maybe a cold stimulus. Trigeminal neuralgia pain. Trigeminal neuralgia, right? So this is all about the secondary headache and the primary headaches that we find. Okay. Now we've got some images regarding the reflexes that we test upon. Yes, this is the biceps jerk, right? This one, if you remember, is the triceps jerk. If you remember, the root value of the bicep jerk happens to be somewhere between C5 and C6. There's a lot of discrepancy here because some of the authors have used only one root value, some have used two root values, but it's better if you use the two root values. That's a better answer. Triceps jerk is C7, C8. Okay, and then we have the supinator jerk, yes, or the supinator reflex. Here again the root value is somewhere C8. Then if you remember this knee jerk, knee jerk. The root value is L3, L4, yes. And then we have this one, which is your ankle jerk. And the root value is S1, S2. So I've already given this mnemonic to most of the classes now, that the root value is very simple. If you remember this old nursery rhyme, 1, 2, buckle your shoes. When you buckle your shoes, you try to wear it on the ankle joint, yes, buckling it up. The ankle jerk 1 and 2, 1, 2, buckle your shoes, S1, S2. 3, 4, okay, kick the door. If you want to kick, you want to extend the knee joint, yes, and the knee jerk, the final effect is extension of the knee joint. 3, 4, kick the door. That is knee jerk, where the extension of the knee joint happens, is the root value L3, L4, right? Then we have got 5, 6, no, 1, 2, that is the ankle jerk, buckle your shoes, S1, S2. 3, 4, shut the gate maybe, or kick the gate, that is L3, L4. 5, 6, 5, 6, pick up the stick. Okay, 5, 6, that is pick up the stick, where the root value is C5, C6. When you want to pick up any stick, you want to flex the elbow joint. Okay, biceps will, final effect will be the flexion of the elbow, yes. And then 7, 8, shut the gate. That is when you want to close the gate with your hand, not kick it this time. Then the extension of the elbow joint has to occur, and that is C7 and C8, triceps jerk. So this is how you can remember all these reflex values. They are very important, common one-liners. Now the next image is some of the release signs that we get in neurodegenerative disorders like dementia. Now look at this. We try to tap the knee hammer onto the lip region, and the person tries to kiss it, like this, pout. So this one is a pout reflex, in which the person tries to pout on touching the lip region. If you remember this, this is like a sucking reflex. When you try to touch the lateral margins of the lips of the newborn baby, he's trying to catch it orally without seeing it. So somewhere it is synonymous with your sucking reflex. That's why I'm using the word primitive reflex here, because if you remember, the sucking reflex was a primitive reflex, and that sucking reflex could be seen like this as a pout reflex in any one of us. But there has to be etiology behind this. Remember this. They happen most of the time in neurodegenerative disorders like dementia. So in patients of dementia or elderly, we can find these reflexes present. Another one is this. When you tap the glabellar region between the two eyebrows, this part, and then there is a sustained up and down closure of the eyelids, that is sustained blinking occurs. This was seen in patients of Parkinson also. We have discussed this in the class. And the name of this sign is a Meierson sign. So there is a sustained contraction of the eyelid muscles on tapping of the glabellar region, is known as a Meierson sign. Okay. Then look at this. We are trying to put two fingers between on the palm of the patient, and he tries to catch it again. Yes. There's nothing but you're again another primitive reflex, that is a grasping reflex, grasp reflex. Okay. Another one is this, you strike the palmar region of the patient, and then there is a contraction seen in this mandible region. Okay, that is known as a palmomeatal reflex. Okay, so you find there is contraction on the mandible region, or a palmomandibulomeatal reflex on stroking the palmar region. Okay, now this one is not related to dementia. This sign, the last one, has been asked quite recently, is the Hoffman sign. Okay, so maybe this image may be a reverse Hoffman, but it's fine, but we should know what is Hoffman sign. Here we try to, catch the terminal phalanx of the patient and extend it. When we try to catch the terminal phalanx of the patient and try to extend it somewhere, in this Hoffman sign, there is going to be flexion of the thumb, and can be some flexion of the index finger also. So on extension, or maybe pulled extension, I can use the word pulled extension because I try to pull it backward and extend it. Pull extension of the middle finger in the patient, of the patient's hand. Okay, there is a sudden flexion. There is a sudden flexion that we find in the patient. There's a sudden flexion that we find in the patient at the level of the thumb and the index finger. Now, what's the relevance of this sign? Like if you remember, we've discussed in the class that there is a sign to reveal a very subtle corticospinal weakness known as a pronator drift sign. Same is a Hoffman sign maybe. Whenever you have an upper motor neuron lesion and a corticospinal tract injury, the patient might not initially come with a full-blown weakness. They might have some subtle weakness which is very difficult to find even on a good clinical examination. So there are some signs which we try to practice on a patient in which you find a corticospinal tract injury in a very early phase, or maybe a phase where the full-blown weakness is not seen in the patient. So maybe in a case of stroke in evolution you find these problems. So Hoffman sign and all these things are basically revealing a corticospinal tract injury. So whenever you have a corticospinal tract lesion in a very early phase, you might find these signs coming in, known as the Hoffman sign, right? So stroke in evolution could be easily found out through these kind of things. Now this is an image which shows somewhere all the different types of eliciting a plantar reflex. Yes, this one. We tried to strike the sole of the patient's foot from the lateral to the medial aspect to the ball of the big toe. You find flexion of the big toe, flexion of all the small toe. So this one is a Bembinski sign. Now what is Bembinski sign positive, if you remember? The plantar is extensor. That means there is extension of the big toe with fanning of all the small toes. And if you don't forget, the movement of the big toe is most important to be seen in a plantar response. And a Bembinski sign positive is an extensor plantar like this. Now what is Bembinski sign negative? A flexor plantar like this. That's a normal thing. So Bembinski positive means an extensor plantar. Bembinski negative means a normal or a flexor plantar. Another thing is open hand sign. We can elicit the same extensor plantar by pressing on the shin of the tibia like this downwards. So that's an open hand sign. What is the Gordon sign? In Gordon sign, we try to squeeze the calf muscles of the patient. So we try to squeeze the calf muscle of the patient, and suddenly again the same reflex could be elicited. So sometimes if you don't want to stroke the sole of the patient's feet, you can try to pressurize the interior end of the tibia, the shin part of the tibia, and then you can see the plantar, that's open hand. And if you squeeze the calf muscle, that's a Gordon sign. And what is Chaddock sign? In Chaddock sign, we try to stimulate the lateral malleolus part, or maybe the lateral part of the foot this time. Foot in the sense the dorsal part of the foot. Okay, so we try to stroke the lateral malleolus and trying to stroke this foot on its dorsal aspect. And again, if you elicit the plantar, that is a Chaddock sign. So Chaddock, Gordon, open hand. 3 different ways of eliciting a plantar response, right? Now these are few interesting images which are showing a sensory loss in anyone, okay, due to a myelopathic lesion, that is a spinal cord lesion. Now the very first image is very simple. As you can see in this patient, there is a continuous loss of sensation, maybe below the nipple region, and you find a complete transection of the spinal cord seen in this case. Complete transection of the spinal cord all across the same, causing a sensory loss below the level of the lesion, is known as what? The transverse myelitis. The transverse myelitis. Or maybe in the patient you might find a sensory loss below the level of the lesion on the contralateral side with respect to the spinothalamic tract. That means the spinothalamic on this side is intact, the contralateral side is lost. Maybe the posterior column on this side is gone and the contralateral side, posterior column, is safe, right? So this kind of a hemisection of the spinal cord, yes, is known as a very great topic. Don't forget Brown-Séquard syndrome. Brown-Séquard syndrome, right? Now you might have a lesion like this, which is involving the central part of the spinal cord, in which a cavity like thing would appear and it will grow laterally. involving the spinothalamic, the motor compartment, that is the interhonsal corticospinal on either side. So this would create a typical cape-like distribution of sensory loss. And that's known as what? Syringomyelia. A myelopathic lesion due to cavity inside the spinal cord causing a typical cape-like sensory loss seen in the patient. Why cape-like? Because I've already taught you this topic in the classroom, that cervical cord of the spinal cord, cervical part of the spinal cord is the most common site of the syrinx cavity to happen. So whenever the sensory loss happens, it starts over here. And this one, yes. Again the same thing, but this time look at this image. The posterior column is involved, not the spinothalamic, which has caused the sensory loss in this pattern. So don't forget, if the posterior column is involved only, what kind of disease are we expecting it to be? Only the posterior column is involved. You can think about one disorder, that is a disorder which comes as a sequelae of syphilis, that is neurosyphilis Tabes dorsalis. So think about Tabes dorsalis disorder whenever the posterior column is selectively involved. Maybe in the case there can be an involvement of the anterior two-third of the spinal cord. Yes. If you remember, the anterior two-third of the spinal cord is supplied by which artery? Anterior spinal artery. So in this case there can be a sensory loss below the level of the lesion on either side involving the spinothalamic, but not the posterior column. So this is nothing but your anterior spinal artery occlusion that we find. Now looking at this, there is a sensory loss which has occurred in the patient in a way crossed. That means on this side of the face we find a sensory loss, and on this side of the body we find a sensory loss. Don't forget, we have discussed this in the class. A crossed hemianesthesia. Yes, crossed hemianesthesia. Crossed hemianesthesia. That is sensory loss of the face on one side. Yes. With a sensory loss on the body on the opposite side. This could occur when the lesion is where? Don't forget, it is the lateral part of the medulla. So lateral medullary syndrome or the Wallenberg syndrome normally present with this kind of a classical sensory loss in the patient. Now this fella, look at this, the face and the body, the sensory loss has happened on the same side. So I'll not use the word crossed over here, I just use the word hemianesthesia in these patients. And don't forget, to cause hemianesthesia, the lesion has to be where? Thalamus. So we find in these patients there is a thalamic lesion. So in thalamic lesion there is a hemianesthesia on the same side. While in a lateral medullary lesion we get hemianesthesia on the contralateral side. Contralateral in the respect of face on one side and the body on the other side. That's why the word diagonally opposite, crossed, is given to it. Right? These images are important. In one of the exam recently we got many questions on them. So that's So that's all about the endocrine part. Now let's quickly go into the, that's all about the neuro part. Now let's quickly go into the endocrine images. Not many like neuro we have got only few images that we have already seen in the classroom teaching. Just a comparative thing, a normal jaw, lower jaw of a child and a jaw of a patient with prognathism, which is protruded outside. So we find that there is a protrusion which is anterior of the jaw like this. So that's a typical prognathic lower jaw in a patient with gigantism or acromegaly. Another thing is regarding the growth hormone, that the excessive mimetization in the frontal region. Like a child, the frontal part of the head is more prominent. So you might also find another phenotypic appearance on the skull of these patients, that is frontal bossing. Right. And this you all know, discussed in the class, because of the protrusion of the jaw, the gap between the teeth increases, yes, and the lower jaw will have a teeth spaced out like this. This is known as the word jaw malocclusion. Jaw malocclusion. Right. Now this is another comparative thing. a normal person with a patient hand of acromegaly. We've discussed this also in the class, that as compared to a normal person, their fingers will be slightly more longer, much broader, yes, with the size of the wrist joint also increasing in them. So a lot of problems happen in them. If you remember, there is a problem which is seen due to increase in the wrist size in these patients of acromegaly or gigantism, that is carpal tunnel syndrome. Because the nerves which are moving into the hand get trapped between the bones of the wrist joint, causing an entrapment neuropathy, carpal tunnel syndrome. As you can see, the hand is much bigger and the digits are much bigger. That's why the word acromegaly came into the picture. The word acro means the digits, okay, and the word megaly means the increase in the size. Like any organomegaly, there is an increase in the size of the digits that we find in them. The rest of the things that you covered in review also, that there is a spade-like appearance of the distal terminal phalanx in these patients. Okay. Now again the same thing again. The person's jaw is protruded out, prognathism. Yeah, they've got large ears also. They've got big ears. They've got frontal bossing. Compared to a normal subject, their nose is also very large and very fleshy. And of course, they've got large tongue. Large tongue would be a very generic word to apply here. We can use the word macroglossia for them. So they're going to be increase in the size of the tongue in them, known as macroglossia. Now, just a view on their height, as compared to their own family members, their own siblings and parents, they're relatively very, very tall. Okay, people with gigantism especially. Now this is an image of the foot of a patient of growth hormone excess. Yes, we have discussed this in your radio classes. They will have increase in this part. Yes, the increase in the heel pad thickness. So the heel pad will increase in size, which you can easily see in the lateral X-ray of the foot region in them. Cushing syndrome, yes, it's a very typical round face appearance with some facial plethora. So this is a typical Cushing syndrome moon-like face, a moon-like face. Right. Now this is to explain the typical pendulous abdomen which happens in them. As you remember, there is some kind of a redistribution of fat which occurs in these patients that might sit down somewhere in the neck region. There's another image on them, but they will have a typical pendulous kind of an abdomen hanging down all the time like this, where of course some stretch marks which are seen in the lower abdomen region, that is known as the striae. So striae could occur in them, yes, stretch marks. Yeah, that's a typical hump on the upper back of the neck region, the buffalo hump. And these two images basically are described to not only cortisol excess but androgen excess which occurs in patients of Cushing syndrome. And you guessed it right, that is excess of hair growth on the face region in females known as hirsutism. Okay. Now the same thing again, this is a patient of Cushing with a typical striae appearance on the lower abdomen region. Yeah, no, this is an image that you all should know about. She's a female who comes to me with a short stature. One thing. Secondly, she happens to have a round face. She's also obese. She's got obesity. When I look at her hand, especially the fourth and the fifth bones of the hand are shorter. And this problem can be seen like this, the fourth and the fifth digits as compared to the other digits is relatively shorter. Maybe a bone in the hand is missing. Yes, the metacarpal bone. Now in these patients, this thing could be seen on the foot region also. So in these patients, you can find shorter fourth and the fifth metacarpal bone or the metatarsal bone. So it's not only the metacarpal, it could be metatarsal also. Yes, this particular kind of a phenotype, the shorter 4/5 bone of the hand and the feet is known as the brachyractile. And you're quite near to your diagnosis. Yes, you all know this. This is nothing but your Albright hereditary osteodystrophy. Albright hereditary osteodystrophy. AHO phenotype. And don't forget that is seen in patients of pseudo hypoparathyroidism and even pseudo hypoparathyroidism. Okay. The sites of insulin that we have got with us, like remember one thing, there are always a recommended site and possible sites that we get. The ideal most recommended site is somewhere in the periumbilical region, in the abdomen region, in the lower abdomen especially. And the possible sites that most of the patient use is onto the arm region just near the deltoid and the lateral, the lower limb, the lateral part of the thigh. Rarely we use it somewhere just above the gluteal region on the back also. Another very important point here is that we should always rotate the injection site. Like, if I keep on giving it at the same site, it will end up doing nothing, good for the patient. It will induce one thing only, lipodystrophy. So if you're giving subcut insulin, you in the lower abdomen region, periumbilical, try to rotate it like this, 1, 2, 3, 4. Even on the lateral aspect of the thigh, it should be 1, 2, 3, 4. Every time we have to tell the patient that they have to take it and have to switch the site. Otherwise, unnecessarily at the same point, if you keep on giving insulin, it will induce lipodystrophy. Same goes, tell the patient again that in the lower abdomen region, you try to rotate the site. Even in that quadrant, it should rotate like this, 1, 2, 3, 4, 1, 2, 3, 4. So every time a new site should be taken from the previous day whenever you tell the patient to take a subcut insulin. So when finally all the images of the workbook are discussed and they are over, you feel happy, kaleja thanda ho jata hai. But the kaleja of yours will get more thanda if you try to get a good rank in any of the exam. Because this image workbook is just a trailer. You find the final picture in the exam. And please remember, the images are very high scoring thing. Either you know it or either you don't know it. If you know the background also, you can crack the correct answer. So try to go to the image book again, try to revise them as fast as possible, and all the best.